Not yet.
How's
Yes,
that? Okay, good.
good.
So hi, everybody. I was honored to be to have the opportunity to talk with you today a little bit about this. Workplace violence prevention in healthcare. And the layers of complexity for this is just indescribable. It is a topic in many discussions, many different places, national, international, local legislatures. So I think this presentation could be days long. And what I wanted to do is just offer opportunities for discussion and just kind of framing up some of the main questions or issues for you all. Because I think just seeing the members on this group, you've all had something to do with framing policy or framing presentations or framing work related to helping decrease workplace violence. So the objectives are to describe general requirements of a healthcare workplace violence prevention program. And I say general because it is pulled from many different areas. Identify opportunities for implementation and describe the shift to patient and family engagement. So we know, and these are just three statistics or three pieces of information. And poor Kathy, if I almost called her a few times because there were so many drafts of this. As I mentioned, it could be many days long. Workplace violence prevention, just to Google that for healthcare worker violence prevention, 22 million results in 0.37 seconds.
Wow.
The American Nurses Association reports 2 nurses per hour are assaulted in the acute care setting. And most, if not all, organizations have some type of workplace violence page and action. So when I look at hospital systems, you can look at their pages and you can see information there. It may be on their intranet or it may be on their public facing internet. OSHA, NIOSH, ANA, the International Council of Nurses, CDC. There's so many organizations that if you would Google and just look at some of those, it's remarkable about how many places have and organizations have information about workplace violence prevention and a lot of healthcare workplace violence prevention. So one area that I thought might be helpful is just to look at what the Joint Commission says. And their standards are now for the behavioral health area, so like those outpatient programs and hospital areas. And they're really getting more specific and inquiring about about various systems, healthcare, workplace violence prevention programs. So there's a few standards that it fits under, and I know that many of you already work with this type of activity. So the hospital manages safety and security risks. So the hospital conducts an annual worksite analysis related to its workplace violence prevention program. The hospital takes actions to mitigate or resolve the workplace violence safety and security risk based on findings from the analysis. So whether you're in New Ulm or Hibbing or Minneapolis or St. Paul or St. Cloud, we all need to do this workplace analysis. And the safety and security incidents are very important. So anything they want to worry about, they want to have us be concerned about occupational illnesses and staff injuries, injuries to patients, and the workplace violence piece that's very important is safety and security incidents involving patients staff, or others within its facilities, including those related to workplace violence. So it's not just staff, it is not just patients, it's visitors, it's anybody that comes through the doors. So that's very far-reaching. And then another standard, that staff participate in ongoing education and training. The training is specified to state that it addresses prevention, recognition, response, and reporting of workplace violence. So what constitutes workplace violence? Education on roles and responsibilities of leadership, clinical staff, security personnel, and external law enforcement. Training and de-escalation, non-physical intervention skills, physical intervention techniques, and response to emergency incidents, and the reporting process for workplace violence incidents. So remember this piece as we go a little further, because it's very directive about what to train. But as we learn later, there isn't very much evidence about, there's little, if any, evidence about what's effective. And then leaders create and maintain a culture of safety and quality throughout the hospital. That the hospital has a workplace violence prevention program led by a designated individual and developed by a multidisciplinary team that includes the following. So policies and procedures to prevent and respond, process to report incidents in order to analyze incidents and trends, process for follow-up and support to victims and witnesses affected by violence, including trauma, psychological counseling if necessary, and reporting of violence incidents to the governing body. So it's all linked. The Nurse and Patient Safety Act that is currently in process of being implemented, due in January of 2025 for the state of Minnesota, has several components, and they're very similar to the Joint Commission. So I bring these two out, both the Joint Commission and the Nurse and Patient Safety Act, because it's very similar. Evaluate risk factors, review violence incidents, report violence, education, review plan annually, and then there's a component about requesting additional staffing if there's a concern about violence. So they're very similar, and one would think that we would be able to use the same types of data sets for this, for the various requirements. They're just sometimes enough different that we need to create some variation in what the reporting is. In January of 2025, for the Nurse and Patient Safety Act, the hospitals need to report to the Commissioner of Health. So layers of complexities. So we have patients and families that come into our sites, into our home care settings, or we go to their homes and home care settings. We have outpatient programs. We have rural, we have urban. So we have people coming in, people that we're going out to serve. We have healthcare teams that are also very complex. And we have physicians, nurse practitioners, CNSs, different people that are providing care. We have nurses who are at the bedside. And how do we work with thousands of nursing staff? And I have so much empathy for our CNO, for our CNOs in trying to direct this work when we're looking at how do we make sure that all of the training and education and support gets to the person that is doing a one-to-one on a patient that might be aggressive, or somebody that's in an ED at night at 2 in the morning. And again, those rural hospitals and rural settings that have not as many services. Healthcare systems, again, we have really large, we have smaller, we have all of those complexities that are in there. How does the lab manage this? What do we do with offsites? And then reimbursement. So there isn't, we don't there's not a lot of reimbursement or availability for reimbursement for all of these services that we need to provide. So this is above and beyond the patient caring or the billing. I know we've been trying to work with some of the medical nurses and what we can do to support them, because mental health, they're used to being able to intervene and doing that, feeling more comfortable with some escalating behavior and being able to de-escalate. But what we're seeing is the medical folks and the medical nurses, that their injuries are becoming higher than even in our site. We were looking at injuries, and there are more injuries in the non-mental health areas than there were. So it's quite concerning. So what do we do? First of all, we can hit the easy button. But we know that there is no easy button. We would push it if we could. And it's so complex, and there's so many different layers with this. It's very interesting to try to chunk it out and see what we can do to work on this process. So I recently did a lit search, and I asked our library services to help with that lit search. So I did one, and then the library did one as well. And I asked for effective de-escalation programs, effective de-escalation interventions, because if we're going to make any more changes, or if we're going to do anything different, it'd be nice to make sure that there's some literature to support that. And I'm learning, and I've been teaching about this, that there's myths. If you follow this recipe, all will be good. If you follow this de-escalation program and you do this intervention at this time, then all will be good, and nothing will happen. Everything will be good. Everybody else will be able to be calm. There's also a myth that everything is easy to solve. So this is a really easy to solve problem. And we have companies that will come in and give reassurances that this meets the Joint Commission standards. This meets the state requirements. This meets OSHA requirements. There's many promises, and if you pay us a lot of money, then we'll make sure that that all of this will be good. The concern about that is that the evidence is kind of internal. So it's a marketing, and I had a colleague that I was talking with about their experience relating to some of these companies, and there is a marketing arm to this. So they want to be able to support their employees and sell the program. But the problem is that there's many promises, but it's super hard work. It's still very, very hard work. So what we learned is there's a lot of incoming about do this and it'll be great, and your injuries will go down and everything will be great. And it underestimates how hard the work is. So when I did that lit search, and the library also did the lit search, I went to the Cochrane Review, and what does the Cochrane Review say? And I was quite discouraged, as others have been that I have shared this with, that education and training programs did not reduce the number of reports of aggressive behavior toward healthcare workers, possibly because these programs made healthcare workers more likely to report incidents. So their numbers continue to increase. And we know that when we encourage reporting and we teach people about what to report, that we're going to see more incidents. An education and training program might improve healthcare workers' knowledge of aggressive behavior in the workplace in the short term, so one study, but we are uncertain whether this would be a long-term effect, one study. Now look at the end of the number of studies that are being reported by Cochrane, and Cochrane has their very rigorous approach, as you know, where they look at randomized controlled trials. They level the evidence, and they do a great job in pulling pulling all of the reports. So education programs might improve healthcare workers' attitudes toward aggressive behavior in the short term, although these reports vary depending on the type and the length of the program provided. and education programs might not affect healthcare workers' skills in dealing with aggressive behavior and might not affect whether unwanted or negative personal effects were noted after healthcare workers experienced aggressive behaviors, one study. So final words were basically that the studies are not reliable and we need more studies. And primarily we need more randomized controlled trials. So I typically try not to review and read a slide. I was so struck by what the Cochrane Review reported that I wanted you to have that information as well. So what do we do? So we had the opportunity at Allina Health to review to review the injuries during a certain period of time throughout the whole system. And I was part of that work group, as the employee occupational health people, staff were as well. And these are the folks that are in the nitty-gritty about understanding the processes, understanding the injuries, talking with the staff, reporting out, doing the apparent cause analysis, and possibly the RCAs as well. And what we learned, and we used the high reliability work that that the Press Ganey company has supported, and Allina does utilize their work for their ACAs and their RCAs and their event reviews. So when we did that, we learned that critical thinking was a main gap. That was the main gap was critical thinking. And it was situational awareness. So knowing what's around you, many components to that situational awareness, knowing how to get out of the way for danger, when to engage, when to disengage from a patient. So there were examples, and this is a fairly common example that I've heard actually throughout the nation, where if somebody goes and if I'm a nurse and I need to take a patient's blood pressure, I need to ask them for permission if I can touch them. And we don't always do that. We just go in, do the blood pressure, and we may be very clueless about what's going on with that patient, that they're starting to escalate. So then the nurse gets punched, right? Or whoever the staff is, they could get punched, or they're pushed away, or they get slapped. So knowing when to disengage, having that situational awareness, knowing when to disengage, and then narrating care, saying what you're going to do, asking for permission for doing that care and touching. So what we're going to work on is we're going to work on a universal precautions type of thing for violence prevention, that we can help staff, all staff, to be able to say, what do I need to do, or how do I pay attention to what's going on around me, to be able to know when to get out of there if I need to, know if the patient is okay for me to be checking their IVs, doing baths, helping them ambulate, those kinds of things. And the literature has shifted. It's been quite some time that it's been shifting over many years. And from a command and control and rules model, more to engagement. And it is not the patient and family engagement with the care team, but it's us, the healthcare team, engaging with the patient and family. And often, many times I have seen, when I've reviewed different incidents and different videos and things like that, where I see where the patient is yelling and the nurse is yelling, and then the nurse kind of walks away. And it's like, that's not de-escalation. That's not patient engagement. I also see too where I think nurses are they have so many things that they have to do. They're so busy. There's so many things that are going on for them. And they feel that pressure to get the tasks done, no matter what those tasks are. So if I need to step back and think about what's happening and disengage from the patient, then how do I still get that work done? How do I still follow through on what I need to do? So we're also going to work with engagement, where supporting engagement at all levels of the healthcare team in supporting patients and families and our staff. So if we have patients that need that extra help, that need that extra work with understanding what's happening in their care, is that a patient that we would do a complex care plan with, or do a high huddle, or whatever type of care conference there is? I had, over the last couple of weeks, I've had 3 situations that have been reported to me where it took a lot of time. They developed they had a care conference, they developed a complex care plan, but it totally stopped all of the injuries. It stopped the escalation of the patient because we were able to have the team there. So the physician, the nurse, the leader, the pharmacy, consultants, we were able to have people there to support developing a plan. And then we need to assure that the team is consistent with the plan. One complaint is it takes a lot of time. Well, you're either going to pay now or you're going to pay later. So it's better off to take care of and developing a plan now so that you can prevent problems down the road. So what does this mean for our work? We're thinking of developing these we are going to be developing some universal precautions. We'll be developing something for staff throughout the whole system. And situational awareness includes like space, tone of voice, knowing when to disengage and get help, and then asking the patient, and we're narrating care and asking permission to touch the patient, show respect, introduce and explain. So we know we've had experiences in our lives, all of us, where people are engaged with us and how well things go. And we also know situations where events do not go well because whoever it is that we're interacting with just disengages. So whatever we do, we're trying to ask our folks, our leaders, to lean in, to use kind of those words, kind of really embrace that if we can work on some of these situations now and these complexities now, that's going to help. So possible strategies, and again, I'm not saying that these are going to work 100% of the time, right? Because Cochrane told us that there really isn't anything that's gonna work. Like there's nothing out there that is 100% effective, and it's a lot of hard work. So we have just some tips that we share with our staff. We don't want to challenge psychotic thinking. We don't want to argue. We don't want to threaten. We don't want to intensely question, use sarcasm or humor. Those are just basic kinds of don'ts to utilize. Now, it's hard. Sometimes what happens is if we start doing some of those things and the patient escalates, if we have situational awareness, we back off. And then you have a chance to correct whatever the interaction is. We do want people to verbalize actions beforehand, initiate active listening, and try to be aware of what may worsen the person's fear and aggression. Take a break as appropriate. Because it's our time frame, it may not be the patient's time frame, and they may need to have more time. We want to be able to comply with a reasonable request, listen patiently and paraphrase concerns, problem solving. And we really want to try to offer solutions instead of taking control. If they have a safety plan, or if we can help them with a safety plan, we can review that or implement that or reinforce that. We want to ask how we can help. We want to affirm their positive qualities, and we want to offer the person a face-saving way out. I don't know how many times patients have said, as I've said, this is the rule, or other people have said, this is the policy, this is the rule. If you say that, then the patients want to see what the policy is. The families want to see that. and many times we don't have written policies. In my novice days as a nurse, there was a patient that ended up like with almost the whole policy book because the staff just kept giving policies because the patient kept asking for them. That really didn't help at all. We learned a good lesson. So it's just more to be really careful with our language and just know that there's some things that just don't have, written policies and things like that. It's a practice. It's what we do. And key takeaways, this is really, really hard work. It takes time. You need to really build the program. It builds on each other and on each element. Be prepared for unexpected issues cropping up. We're working on one thing that Alina is that we do, and I wished I was there to help develop it. It's a really great project. Is the agitation protocol. We call it the agitation protocol, and it was developed by Suzanne Wiederholt, who's a psychiatrist, and Eric Haug, who's an ED physician, and Alina, and they just scribbled on a napkin one day when they were either having dinner, lunch at the bar or whatever, but they just started kind of mapping this stuff out. And the agitation protocol is implemented in mental health and emergency department at Alina-wide, and we're working on expanding to the rest of the system. But what this agitation protocol is a behavioral activity rating scale, so a BARS. That's what the nurse assesses. And then there's the SUDS, it's the subjective units of distress scale. So it's a patient report. So the patient may appear calm, but they may be just very anxious inside and very fretful and worried and and feeling very agitated inside. So we use both those scores to do interventions and they are engagement interventions. So what can I help you with now? What would help you calm? What would help support you? We have different levels of validation. We have different levels of engagement. It's not a randomized control trial. We do have medications that are, if the bars and the SUDS are this, this is medication that you can offer the patient. Again, Cochrane wouldn't approve of it because it's not a randomized controlled trial. We are trying to help staff though with some interventions that would help engage the patients. So that's something that is a big project that Alina is doing, and we are seeing success with helping staff know what to do and patients feeling more heard, more engaged in their clinical care. So now time for discussion. What questions or what discussion? I'm learning all. I will learn all from you as well, because I just would like to open it up for discussion. Thoughts?
This is fabulous, Nikki. Absolutely necessary. One thing that I'm drawing a parallel to is we encourage a lot of our clients to engage in something called mental health first aid, where you're kind of bringing leaders and frontline staff along to help them understand what a mental health crisis might look like. What are things you could say? How can you get help? What questions are appropriate to ask? So it's just really, it's first aid, but for mental health. This is very much aligned with that. And there's been a lot of research around the efficacy of that model. So this is fabulous.
There's mental health first aid, there's psychological first aid. It's really cool. Some of the, and some of those are consumer programs as well that are really great for families and people that are out in the community to do this. So thank you for bringing that up, Heidi.
I appreciate you sharing, Nikki. It's something that's like a buzzword right now, workplace violence, and there's a lot of advocacy around it. So knowing what you know, seeing what you see, what would be your primary goals to advocate for with for political bodies or local government? What do you think would be your pie in the sky situation? Hey, can we pass this or do more of this?
My pie in the sky would be to have funding to allow all of this training and to give people time to be able to digest this, to be able to create this, this work. There's no wiggle room. So if you have patients that require more time or more effort or different interventions, there's not a lot of time built in. And again, I feel really bad for the CNOs and people that are trying to do this work, because there's not a lot of wiggle room. You have to train about this, you have to educate about this, you have to make sure, and education is not a one and done, as you know, right? So it's not like you just don't do it one time. This takes a lot of work and teaching and supporting and role modeling. If we could ever get funding for this throughout the whole nation and internationally, I think that'd be really cool. So I don't know how that is a really big lift, right? Because I think a lot of violence prevention is being with people and feeling comfortable to do that and help them along their journey. So what ideas do you have, Berg, about fixing this or working on this? What's your pie in the sky?
Well, I would be looking upstream. I mean, as healthcare providers, we only have so much control over how we're approaching the situation. And I think another question to ask is, do we have data showing that the other side of the table or whatnot, are we experiencing more violence in general in healthcare facilities, and why? What are the communities going through? What community options would there be? Personally in different neighborhoods, I've seen a significant increase in stress and aggressive behavior and yelling since the pandemic. The pain doesn't necessarily stop, especially when you're already behind on life. You don't have the tools to cope with it and move forward. Things just kind of, they don't always get better, unfortunately. So I think I would also advocate for more time with patients. And I think that comes down to reimbursement structures and priorities of our healthcare system as a whole, because I think when providers are rushed, it adds more stress for the patient. From a personal perspective, I've been in visits where I come in relatively relaxed, but it's clear to me that my provider and the person working with her, they're trying to get their job done. They're trying to do a good job and meet their metrics and whatnot. And but that comes at a cost. So I think looking at those perspectives and the amount of time.
Excellent points. Thank you. Helpful.
So Niki, this is Deb. Hello. And
hi, Deb. How are you?
Good. And one of the things as you were talking, and I know we have to always start somewhere, so I think focusing on the, direct care staff is usually where we start. But how are you thinking of, or how is Alina thinking about engaging the entire healthcare team in this work? So, because there are so many other team members who interact with our patients, that the nurses, yes, are there, frontline people, but other triggers can be there for patients that are not the nurse. It can be someone coming to take a lab. It can be a provider giving bad news about a situation to not only the patient, but the family. So how has Alina been thinking about all of that?
Excellent point. And I say nurses, and I am, of course, I am a nurse, so I get a little biased to nurses. But we know
Rightfully so.
right? But we have lab that goes in there into the rooms. We have nutrition services that goes into the room. They also need to have the support and education, volunteers as well. So I'm anybody that is walking in the doors or in a home care setting or wherever they are, we're working on, we're going to target for this universal precautions, which will be the physicians as well, because I know sometimes that our, one of the physicians, we were in a hospitalist meeting just describing the workplace violence prevention program. And they said, you know, the physician said, I went to this violence prevention in-person training, which includes basic elements of de-escalation and also some in-person like self-defense techniques. This was the best class ever, she said. And it's like, I would recommend it to everybody. It's like, it's been offered. You can go anytime, but they kind of think sometimes that maybe they don't need to, that they're perhaps immune. And I know I'm not telling you anything new. So it will be everybody that we will touch. I think what Alina also has a few different, like they have a green placard on a door, which is similar to the check with nurse that you used to use, where please don't go into the room without checking with the nurse. So there's that symbol, because we also need to work with staff who have no access to the electronic health record, or are too busy or are going in to help a patient. They need to know about that patient and they may not be able to always see the record. So yes, we will be including all staff. And I'm excited about that too, because it's more, how are we going to make sure that we touch everybody that we need to? All of those people that are in a central lab where they're not in a like a hospital, they're in a corridor, and how do we make sure that they're supported with violence prevention? And the parking people, I mean, the parking people have a lot of sometimes unfortunate and angry interactions with people. So definitely EMS, you know, the same. So we'll be touching everybody. So thank you for raising that. And sorry for my nurse bias.
No, we all have it, so it's good.
Right. So Nikki, this was really, really helpful. So one of the things that comes to mind is, you know, when we talk about, okay, so dementia care, and so then regulatory, we end up with some of those kind of regulations that says you have to have so many hours of training of this. And you know, I'm not a fan of always having regulations around it. But there's a couple of factors that really this is costly, right? From a workman's comp perspective, from people getting out of the field, and fines that can happen with those kinds of things. I mean, there's just so much additional things that it makes you wonder if from a JACO, from a CMS, all those kinds of areas, that if a regulation isn't necessary to start to look at this training as being more mandatory. Like I said, I'm never a fan of total regulation, but sometimes the educational pieces that we are required do help.
Totally. That's a great point, Cami. If there are regulations, it's nice to have the funding to support that, right? I know OSHA, with federal legislation, there are bills that are in process right now to codify the OSHA requirements related to workplace violence prevention. It's just, so if we're gonna have those, then let's have funding so we can support, like you say, the training, the education, and not just the one and done education, but the ongoing work that needs to occur. I would love if we could say every patient gets the opportunity for having a care conference and the whole team comes together and we can do this complex care kind of thing. And if we need to bill for it or whatever, but how do we get funded for some of this work that needs to happen outside of the 15-minute med checks or whatever is happening with the work. Plus we have all of our students and residents, and those are all people too that need to have this education. So great point. I don't know if I answered your question, but there's a lot of stuff going on with this.
It is, and I think that it's not just the cost of the training, it's the cost of people's time and training. You
Mhm.
know, that's what really often gets you. You can get these great programs, but then when you start to really roll them out, they're so costly to really put people's time into it. But I agree with you that there has to be some funding that goes along with this, because at what point do we, I mean, we talk about safety, we talk about all those kinds of things, and at what point do we not put our money where our mouth is?
Exactly. And is it one more thing for the leader to do? So leader, here, charge nurse, make sure that you're doing all of this other stuff too, as well as all of your hand hygiene audits and all of your, complaints and all of this stuff going on. So it's it can't it cannot be a pile on kind of thing.
Right.
For
I,
for me, I think of this as the fabric of if I could inject a nurse with universal precautions for violence prevention and have
Yeah.
them get this, wouldn't that be cool? But we can't. So it's kind of like who I need to be as eat, breathe, and live. We were talking today at work about this, about how med surge people, they are clueless when we do this. I was talking with a couple of, I'm one of the mentors for the clinical scholars for two nurses that are, one is in mental health peds, one's in mental health adult. Just really exciting to work with these nurses, newer nurses. And I said, have you ever realized that when you're talking with each other in the hallway of a mental health inpatient locked unit, that you stand so you can watch each other's back? Did you ever know that you did that? And they said, oh my gosh, we do that. We do that. And I said, but med-surg doesn't get that. They don't understand that consistently. So that's the kind of stuff that you are, that's embedded in you, that you do that. So that's what we're trying to work. We're going to try to figure out something for our mental health nurses to maybe partner with some of the med-surg units, like the higher risk units, to possibly teach them some of these interventions to see if that helps their confidence with working with aggressive patients or working with patients that are destabilized.
it makes you also just wonder, and I'll stop, but it also makes you wonder now, at what point are we really introducing this into our educational systems in nursing schools? Because nurses really do drive a lot of that. And if we had every nurse going out there fully trained in this and having that, it would probably have a pretty widespread impact. So
Almost like a Sims unit where
Recording in
role-playing
progress.
happens.
Totally. And sometimes it's helping people be comfortable with loud voices or loud noises. And there's so much trauma. We talk about trauma-informed care, and it's trauma-informed. Me as a healthcare worker, my trauma as well. So we have many trauma experiences that need to be worked through, and that's the layers of complexity. I mean, again, this could be days long. So
Celeste has her hand up.
So I didn't want to interrupt anybody, but you know, we talk about training a lot and the cost of training and more money for training. And we at Health Partners, we talked about that all the time too. And of course, we know that training can be effective, but on the other hand, the research that you presented is that training was not effective, and that is what we saw over and over again. And so, you know, you don't want to pour more money into training if it's not effective. So in your opinion, do you have an idea for what might be effective training?
universal precautions. So how I am with patients, delivering trauma-informed care, asking permission. So that whole universal precautions of making sure that I'm surveying the environment before I go into it, and being kind, not pissing people off. That I I have seen so many situations where the patient is yelling, the nurse is yelling, and it's like, that is not de-escalation. And people say, well, duh. And it's like, then why do we see it all the time? So kindness, caring, explaining what's happening, those universal precautions, kind of that maybe a civility in some of our interactions. That's not going to fix everything, but trying to have people feel confident. And that's what, after more years in psych, I've been a nurse since 78. That's a lot of years. I've been a psych nurse since 81, and I just grieve all the times that I've taught and said, if you do this, everything will be okay. There's no recipe. There was a recipe, but there is no recipe. So that's why I'm really going after that whole universal precautions and really trying to work on teaching that. So does that help, Celeste? I mean, that's only me personally, and I think we learned that from our data, then when we looked at the injuries about what was missing or what the gaps were. But in 5 years, maybe we'll see that it's something different.
Right. No, I agree with everything that you said. I think somebody touched on it right before I asked my question too, about in terms of how we do it. And I think a simulation, like if we had to do training where we didn't just watch our video and answer some questions at the end, but everyone had to go for an hour simulation where they actually were in a situation. I just feel like that would be so much more effective.
And role modeling how to work with a patient. So teaching just in its simulation in a different way too. I like it on the units or in the work setting about being able to role model and see those folks doing it well.
Right.
And having that time to partner and buddy and approach a patient with two staff if you need to, if the patient is complex and you need to have that support. So Align is also working on a neurodiversity questionnaire. So Laura Gensler, one of the nursing directors, had an AONE fellowship, AONE, I think, fellowship. And she found a neurodiversity tool or an autism care tool. And we've since taken that and utilized it. We have a behavior analyst also in our mental health and addiction service line named Dr. Jamie Hughes. So with her specialty with autism and also us saying, we've developed this tool to say, how does the patient eat? How do they toilet? How do they take meds? How do they express themselves? One of the units used that tool, found it, used it for a patient that has dementia. It worked beautifully. So it's like, so now we're going to implement that as a tool for us to understand more about the patient's patterns. I mean, this is like not rocket science, but it's like, why didn't we do that years ago? So it's like, okay, we'll do it now and we'll just keep moving forward. But whatever we can do to help people know ahead of time and then go from there.
Yeah, thank you. That's a terrific suggestion right there. Thank you.
I think in this conversation you've just been having, I think the gaps was the key word. I think we can educate until the cows come home. And if that's not what the issue is, that's preventing people from being able to implement, they can know the skills or the techniques or whatever from here to eternity. But if there's some other barrier that's keeping them from being able to implement that in a clinical situation, then we need to rethink about what we're doing or what kind of support, or like the simulation, if that's what they need. So it's really getting at what the heart of the matter is that's preventing nurses and others from implementing.
Great point, Patty.
Well, I've always found that doing the postmortem too, like what could we have changed that when this didn't go well? So that kind of continuous loop of learning. And Gertrude has her hand up.
And Kathy, that's a great great thing too, that we've kind of forget to do that. Let's do the check step, or hey, did this work? Did this not work? That debriefing piece. Totally.
And bringing more people into the debriefing instead of just the leaders.
Exactly.
Yep, my name is Gertrude Thomas. This is my first time attending the meeting. I'm glad to be here. This was a great
Welcome.
Yeah, thank you. And I'm glad you mentioned the trauma-informed care as a missing piece and the neurological assessment as another tool that could be used. I was recently at the AONL conference, and one of the immediate past presidents presented on this issue as well. And for her, what she highlighted was what's happening now, not to blame it on nursing 100%, because we're seeing all of the casualties that are coming to nurses and healthcare workers. But she's saying nurses are humans, just like any other person coming out of the pandemic. We have our own stressors, and we are entering the healthcare environment with the us against them mentality. And that really does not help when it comes to de-escalating situation. Just like you mentioned earlier, I've been caught up in between the nurse and the patient, and they're screaming. I'm a leader at the University Hospital on the West Bank on the med-surg unit, so we see all of those patients. I'm caught sandwiched between the nurse and the patient on the screaming match, and don't scream at me, don't yell at me. And it just messed up everything. And you, as the leader, the nurses are looking and trying to figure out if you're going to take sides. They want you to turn to the patient and give the patient a stern warning and say, you cannot talk to my staff nurse like that, which does not help the situation either. So really adding into de-escalation the trauma-informed piece and the whole neurological piece for people to know that when people are traumatized, they are in that flight or fight mode, and they are not thinking with their whole brain. So whatever they can do to just react instead of thinking and responding, that's what's happening right there. So yeah, the trauma-informed care piece is really vital to honing this home for nurses and for all healthcare workers.
Thanks for sharing that, Gertrude. I also wish too that we would be, I know we teach this in some of our physical intervention classes, that if I'm too connected or too hooked with this person, with this patient, that I need to back out and let somebody else take my spot. Some people call it tapping out, some people call it handing off. So if I'm finding that I want to yell at a patient, or that I am yelling at a patient, how do I disengage? I need to disengage from that as well, right? And let somebody else kind of go in there and work with the patient.
Yeah, which is hard to do in the moment.
Totally.
And if you're not emotionally aware, you're not going to back off. You know, you're in that mode.
Yeah.
I remember from a situation at St. John's several years ago where nurses were hurt. I think there were 4 of them that were hurt by a very violent man that took the end of the bed off and used that as a weapon. But the part that I remember most, and being part of quality at that time, I had an advantage is that I didn't work. I was responsible for quality on that unit, but I wasn't taking care of or that. But what I noticed in coming in and out of that unit for many weeks after this happened, how hard it was on the other staff that had to care for those patients, their colleagues, and then provide care for other patients, because they became very fearful of what had happened to their colleagues. And I know that there's probably one that still has been very affected by that. She was very hurt. And also the security guard that had to come in and handle all of that. I don't know that I think he left that position because, so yes, this is such an important topic. And after observing that from my perspective,
of just an observation. If I was able to pick up on that, how that must have been for each of those colleagues that had to go back to that unit and take care of their colleagues, but also other patients. It became very fearful.
And how do you support and how do you care? And I know Alina experienced the Buffalo Crossroads shooting as well, and health systems are experiencing these horrific actions. And again, our leaders need to work on, they need to help make it right, make sure patients are cared for, staff are cared for, that all of that happens. And then you have all of that trauma that occurs. And plus, usually if there's an event like that, you have all of the investigations that occur, right? So you
Yes,
have
right.
police investigations, you'd have, I think there was a death, that patient died too. So medical, I mean, all of these investigations, CMS, Department of Health, all of those people that come in to do investigations too, which then re-traumatize the staff and the leaders and everybody that is trying to, it's so hard. If we can do whatever we can to prevent, and I know we can't all of it, but whatever we can do to prevent, then it just helps so much. And I am so, I'm so sad for you having to go through that and your staff. And I remember when that happened and it was just horribly tragic. So much, so horrible.
Yeah.
Stephanie, I wonder if you have anything to say about the ambulatory settings. I think of a nurse who was taking care of a home care patient in Washington State and was murdered. And you know, it's one thing in an acute care or long-term care where you've got a team around you all the time, but when you are the team, what do you think?
Thank you for bringing that up. I've been thinking about making some comments about ambulatory. At this point, at least what I've observed isn't quite as usually, I should say, isn't quite as extreme as some of the situations that the inpatient units are encountering. But there certainly are examples that I encountered in my years in primary care that gave me pause, because we're ill prepared as a clinic sort of setting for behaviors that patients experience. For instance, one of our care coordinators that we had in one of our smaller facilities had an office that opened up into a hallway. You would never think anything about that, but a patient who knew where that office was walked in the front door and walked all the way back to her office and walked in her office and closed the door behind him. Without anyone really knowing. And there really aren't controls in most of our clinic settings. If you have someone who really looks like they know what they're doing and where they're going, it's less likely that someone's going to stop them. There's certainly examples in which we've had physicians or nurses in exam rooms. And because of the design of a typical exam room where you have the patient in between the provider and the exam table and the door, there are situations where the provider was unable to get to the phone or unable to really seek help, and the patient was threatening between him and his only exit from that exam room. And so there are, we've been trying to promote ideas around changing that design so that the patient is not between the provider and the door, but all of those things happen very slowly. So there's sort of environmental design issues that need to be taken into consideration, because our clinics are pretty wide open for the most part. And then there's design issues in the spaces as well, and access to those spaces. And of course, many patients are coming in and they are in crisis of one kind or another. I know pediatric units sometimes become very difficult because you have parents who are no longer together, that may come to a pediatric appointment with the child, and maybe not agree with the care that's happening with the custodial parent, and put the staff in the middle of a huge issue between parents when the staff are really unprepared for how to manage that, or what the rights of each parent is, and what you should be doing about that. So there's just so many situations that occur in ambulatory care settings as well.
And we don't think about the design typically, right? We don't think about all of those isolated offices and the thoroughwares and thorougways, and we don't think about that. And I remember even when computers got installed, we didn't think about where the computer was situated and what that does to me when I'm trying to work with a patient. So those are all, I mean, and unfortunately, one thing that I wish I could do in my career is have people think strategically and think about safety before there is a problem, right? And unfortunately, sometimes what happens is people think, well, it'll never happen to me, or it's never happened here, until it does, and then it's just so difficult and so tragic. So just whatever we can do.
Yeah, I've never seen the Buffalo clinic in which the active shooter came into the clinic, but I assume it's probably like every other primary care clinic all across the state or across the nation. And something like that could happen literally anywhere at any time.
And consultations that I've done as well have been with reception folks.
Yes.
How to help those people that are at the front desk work with escalated patients and stay away from the harm. So
yeah,
it's if our work is never done, right? This work will never be done. We have a lot to do.
There's just so much anger in our population right now, it seems like.
I was just thinking if with the training, it might help with the population in general too, like knowing when to disengage at home in a conversation and knowing when to do all of that stuff, that the things you learn for work can have a ripple effect on the rest of your life, which is really quite wonderful. But any other questions? I see that we're at the end of our time.
I have one more comment, and I'll be quick about it. I was actually just typing it in the chat, but since we're gonna get zipped here soon, you mentioned Kathy, the home care nurse that was murdered, and that's terrible to hear, and I'm sure for her family and whatnot. Having worked in home care, I personally feel that it can be a safer environment for day-to-day nursing because the person feels so comfortable. They're in their own home. They feel safe. They have control. They're in their own clothes. And it's interesting to think about these designing spaces, which was another thing that I thought of when we're reporting these incidents of how many doors were available to the patient when they were feeling aggressive. Were any of them open? Do we offer to keep doors open? But thinking about how we have to protect our supplies, we have to protect medication, we have to protect our staff in designing the spaces. This is an inherently us versus them concept of design. And how do we hold that at the same time that we're holding, how do we make this person feel comfortable and welcome? So, I mean, it's a complicated issue, and I commend you for your work, Niki.
Well, and Berg, you saved like one of the most, I mean, you're exactly on target, right? How do we have a welcoming space and stay safe? I mean, it's not that, like, what is it called? Burying the lead. I mean, you kind of buried the lead. That's so huge. And there's so much work to be done with that. So thank you for raising that.
I just wanted to jump in, and I know we're over time, but just wanted to say thank you so much for the discussion today. And as a nurse that's worked inpatient and clinical and in the community, I've really kind of experienced it all, but kind of piggybacking on what Berg just mentioned, the most recent community clinic that I worked at, what was planning on building their new facility, and really with an intent to be trauma informed, and that was both for patients and for staff. And so really the entire design was based on how can we keep patients safe and calm, and also make sure that we have exits and opportunity for staff to get away safely, without, making a patient feel as though they're trapped in the space and have no place to go. Because as we've all talked about many times this evening, there's just a lot of trauma, and a lot of emotions that aren't often, people don't often have the ability to work through those. And so I think we are dealing with more complex issues when our patients walk in the door. So really appreciate the discussion.
Thank you for raising that. I can't tell you how appreciative I am of the comments and of the discussion. We have so much ahead of us that we need to do, don't we?
Yeah. I have just one quick question, Nikki, sorry for our time frame, but a lot of the comments has to do with hospitals, it sounds like, but I'm wondering about healthcare settings for our senior members. How does this topic relate to that?
Good
I
question.
as far as I think it's care anywhere, right? And our and I know there's our seniors are more at risk for injury, right? If they get in the way of, if another person is, I can't speak to about situations that are confidential, how you get involved in stuff. But we have our vulnerable folks that are needing support and protection and safety, and sometimes we're all mixed together. So I don't know that that's capturing what you say. Mary, this goes to assisted livings, right? Wherever there's staff, wherever there's people, wherever there's people that are together and living together. We have to have a kind society, or try to have some kindness, and I don't know.
So Nikki, I'll just add to that, just because this is kind of my little area.
It's your stick, isn't it?
It is. I think one of the challenges that we have in long-term care and assisted living, and that is that there's an expectation that we just put up with it, and that nurses, that it's acceptable. And when we look at discharging, and Berg, I see you kind of shaking your head, you know what I mean. When we look at discharging people, we can't discharge them for those kinds of things unless it's really, really severe. And so we end up in this quandary where we don't have a safe residence. We're trying to keep other people safe, and we can't keep our staff safe. And so there's been, and I think it's historically, right? Historically, it's been, oh, they have dementia, and we just accept that that's who they are and that's what they do, and you just try to stay out of their way. But yeah, right, Berg, you can't get an order. We can't restrain people. We can't, you know what I mean? And so there's all these things that we can't do. And then we can put people at 1-to-1, but then it talks about the same things that you have in the hospital where they're just as at risk. So long-term care and those kind of community living situations are a lot tougher, especially around regulation and getting people into a different situation. And you can have the police come, but unless they're really doing something at the moment that they walk in the door, they're not going to do anything with that that elderly individual. So you can call the doctor, and the doctor's going to say, well, the hospital won't do anything with them, and nothing more. They can't do anything more at the hospital than what you're already trying to do. And so it's just this, it really is, I mean, it is an area that really could use a lot of focus on it. And I'm not sure what the answers are really.
Well, and I wonder too about that healing spaces again, right? So can we build settings so that we don't have people kind of on top of each other, and we have more space, and we have you know, the ability to do different kind of activities and things like that. Go ahead, Mary. Were you going to say anything? Oh, okay, your picture came on. It's like some of our buildings are so old. Some of our, you know, it just takes a lot to retrofit things and build things, and we just need to kind of catch up, it seems.
Agree.
And prioritize.
Right.
If I ever win the lottery.
When do you win the lottery?
I think we'll need everyone to win on this call to win the lottery to do what we need.
Yeah, and that's just for our little neck of the woods in Minnesota. Yeah.
That's right. We'll be the example. And then we'll let New Mexico come in. So want to just really thank you, Nikki, for this great presentation. And as challenging as it is, it's really hopeful too. And that's really wonderful. So you'll get everyone will get an evaluation tomorrow, and then your certificate after that. And our next meeting will be on May 21st, where we tackle the issue of nursing education from pre-licensure throughout your career. And so we're going to solve it within an hour. It's going to be amazing. Stay tuned.
Well, thank you, everybody. I so needed the discussion. You know how you get, thank you. I needed the discussion. That was purely selfish. And your chats and it was just great. So thank you.
I'm sure we're going to have in the evaluation at least one person saying that we want you to come back
Oh,
and
yeah.
tell us how it's going.
Exactly.
Okay.
Thank you all.
Thank you.
Thank you.
Bye-bye.